Thank you, Dr. Shreya, for that generous introduction. At the outset, I would like to thank the scientific chairperson of the AIOC and the AIOC team, and Dr. Shreya for bringing me here. So I will be talking to you about regaining stem cells and limbal stem cell loss. We all know that the cornea on the front surface of the eye provides our window to the world. And maintenance of this corneal transparency is dependent on the integrity and functionality of the outermost corneal epithelium, which itself is maintained by the limbal epithelial stem cells. If this adult stem cells population is depleted by injury or disease, the transparency of the cornea and therefore the vision is threatened. So limbal epithelial stem cell deficiency results in corneal opacification, inflammation, vascularization, and severe discomfort. The stem cells are present in all present in all self-reviewing tissues and have a unique properties. The ocular surface is made up of two distinct types of epithelia, the conjunctival epithelium and the corneal epithelium. Though it is connected to each other, the phenotypically both are very different. The stem cells of the cornea are located at the limbus. The microenvironment of the limbus is considered to be important in maintaining the stemness of these cells. They also act as a barrier to the conjunctival epithelial cells and prevent them from migrating onto the corneal surface. So in certain pathological conditions, the limbal stem cells may be destroyed partially or completely, resulting in varying degrees of stem cell deficiency. With its characteristic clinical features, these include conjunctivalization of the cornea with vascularization, appearance of goblet cells, and an irregular and unstable epithelium leading to recurrent epithelial breakdowns. As you can see here in these clinical pictures, they are all labeled. Like first slide shows that he was a welder. Because of chronic actinic damage, he developed double pterygia-like appearance, a patient with OCP and chemical injuries in the bottom line. These are the other causes, like a young patient with chronic soft contact lens wearer ended up with limbal stem cell deficiency and chronic VKC with LSCD. So these are the etiological causes. Broadly, it can be divided into congenital and acquired, and you can go through the list. In the interest of time, I will not go through this. But if we can put it into a diagram, the majority for unilateral LSCD, the majority causes chemical injury, while for and the others comprise the 20% of the injuries. The bilateral LSCD, the causes are different, but still here, VKC and chemical injuries and the chronic cicatricial diseases make the most of it. The corneal transplantation alone is ineffective in limbal stem cell deficiency, as it results in recurrent epithelial breakdowns, surface healing issues, and ultimately graft failure or sometimes graft melt. So fortunately, limbal stem cell transplant can restore normal epithelial phenotype and re-establish a stable corneal surface. In patients with LSCD, the healthy fellow eye can serve as the source of donor limbal tissue for unilateral buns, while for bilateral LSCD or limbal stem cell deficiency, when the autologous limbus tissue is not available, one can resort to donor limbal tissue, either a cadaveric or from the living related donor. So previous strategies to correct limbal epithelial stem cell failure include transplantation of limbal autografts or limbal allografts from a donor. Both have drawbacks, including the potential creation of limbal epithelial stem cell deficiency at the donor site or the requirement for long-term systemic immunosuppression in cases of allografts. So coming to techniques of limbal transplantation, also recently it is more known as limbal stem cell therapy. If you look at this algorithm, the first and foremost part of treating a limbal stem cell deficiency is controlling the inflammation of the ocular surface. That is very important to maintain the stem cells which are transplanted from the fellow eye or from the donor. So this is the most important part. Then we can divide it into partial limbal stem cell deficiency or a total. If it is partial, patient could be asymptomatic, which can be just treated with medical management, maybe occasionally with lubricants and occasionally with topical soft steroids. If the patient is symptomatic, they might require amniotic membrane transplantation or sometimes sequential conjunctival epitheliectomy, which was popularized by Professor Dua. Ipsilateral limbal translocation also can be done. For total limbal stem cell deficiency, if it is unilateral, one can do a conjunctival limbal allograft or a SLET, which is known as simple limbal epithelial transplant, or a CLET. If it is bilateral, and one can use either allogenic based limbal transplant, which could be from the donor. There are various things. We may not go into that detail. The reason being that we would be addressing more of a chemical injury here. Just briefing about the basic terminologies, like conjunctival limbal autologous transplantation is a procedure which includes obtaining 2 grafts of 2 clock hours each from limbus and the adjacent rim of conjunctiva from the patient's other healthy eye. This procedure has the longest track record and has been shown to successfully restore the corneal epithelium in approximately 75% of the cases. But drawback is it creates a limbal stem cell deficiency into the donor eye. Then came the cultivated limbal epithelial transplantation, wherein Pellegrini and all described cultivated limbal epithelial transplantation, where they took 2 by 2 millimeter piece and then they expanded it ex vivo and transplanted. It takes about 2 weeks and transplanted onto the recipient eye. Then in 2012, Sangwan et al. Described the technique of simple limbal epithelial transplantation, where a strip of donor limbal tissue from the superior limbus, similar to clot, is obtained from the healthy eye, but instead of ex vivo expansion, it is divided into small pieces and transplanted directly onto the affected cornea for in vivo expansion over a human amniotic membrane graft. As you can see here, there were certain modifications which were popularized, like sandwich technique, where double amniotic membrane is used combined with conjunctival autograft. It was also combined with mucous membrane graft. And recently, people are describing slut with amniotic membrane without amniotic membrane and directly applying these pieces onto the recipient bare stromal tissue. We may not go into the details of the results, but to simplify for the clinician, if there is a conjunctivalization in the peripheral part or there is a partial LSD, there is no need for slut. You can just go ahead and do a conjunctival autograft. You can, do tarsorrhaphy along with or depending on the need of the hour. If it is conjunctival, peripheral conjunctivalization of the peripheral cornea plus central corneal superficial stromal haze, one can do a conjunctival autograft and or slut. If there is a total limbal stem cell deficiency but not much of a central scar, maybe probably slut is a good option with or without conjunctival autograft. This is a pictorial representation from a very recent publication from LV Prasad Eye Institute. You can see that slut is recommended in the top row, while slut plus conjunctival autograft is recommended in the other, and bottom 2 rows, slut is not recommended at all. So we look at quickly clinical cases. This is a bilateral acid injury patient who had injury of different grades, developed pannus in one eye. So we ended up doing a pannus resection from the pannus resection with a conjunctival limbal autograft from the fellow eye, as you can see here, and his vision improved from 624 to 69, and a temporary tarsorrhaphy helped in stabilizing the surface. This is a video of the same procedure. As you can see here, if there is just a pannus, you don't need to do a slut. You can just remove the pannus from the corneal surface, do a conjunctival excision there, allow the conjunctiva to fall back, remove the tenons, clear that area carefully, and then you can take a donor tissue from the same. I'll just quickly run through the clinical pictures only and apply it there. So this is harvested from the fellow eye, as you can see here. Along with that, I've taken a small limbal ledge. So it is, instead of conjunctival autograft, you can call it as CLAG, conjunctivo-limbal autograft. And this is put onto the recipient eye, as you can see here, and attached with a tissue glue. But you have to be very careful that you have to keep it little away. The conjunctival part should be kept about 1 millimeter or 2 away from the limbus. The reason being that you allow the corneal epithelium to cross over rather than the conjunctival epithelium to cross over the other side. So this is another case with a bilateral acid injury, responded to BCL and medical management initially, but later developed localized LSCD. As you can see here, recurrent redness episodes, and he needed a conjunctival autograft, and I did not do a slut here. You can see that he underwent a pannus resection, conjunctival autograft from the same eye, and he did very well. This is another case, 10-year-old male child with Lyme paste injury. You can see that we did a conjunctival limbal autograft in this case, and the cornea behaves very well. He had also restriction of eye movements. This is a 28-year-old male who presented with Lyme paste injury. He had undergone twice, tenonplasty and amniotic membrane elsewhere. Came with recurrent red eye, restricted eye movements. As you can see, the lid is attached to the cornea or the globe. Symblepharon with pannus with near total limbal stem cell deficiency, shortening of the fornices, and the eye was quite inflamed. After covering the inflammation, we went ahead to do a slat and a conjunctival grafts on both the sides. Almost 360-degree conjunctival grafts from the fellow eye were taken. Both the grafts were taken from the superior part, as you can see here. You can see that limbal tissue being dissected. About 2 by 2 millimeter limbal piece is dissected, and it is cut into several pieces and applied onto the recipient bed. Here you can see that the conjunctival graft is covered. It works as a barrier, so it doesn't allow the symblepharon to occur later on in the recipient eye. And then this was covered with amniotic membrane, and then you can put your slat explants onto the amniotic membrane, put in a bandage contact lens, and then a small tarsorrhaphy, temporary tarsorrhaphy kind of, which can be there for 2 weeks to 4 weeks depending on how long you want it, clinical progress. That would work very well for these cases. You can see that small pieces are made out of that limbal tissue. A very small tissue is required, and this is arranged and tissue glue is being applied. Once it sets onto the cornea, BCL is put and the tarso is applied. This is the post-op result of the same patient. This is almost 5 years post-surgery. You can see that the cornea is looking very well, the donor as well as the recipient cornea. This is another case where we had done here we have used a variation, like, it was a donut kind of a amniotic membrane where we just allowed the central cornea to be without the amniotic membrane. We have applied the slat into a restricted area where the symblepharon was there. So you can see the results in the last picture. This was a case of total limbal stem cell deficiency. She underwent 2 amniotic membranes. She had a vitriolage, and then she ended up with 360-degree limbal stem cell deficiency. You can see we have done a slat, and the cornea looks much better. Here we did not use conjunctival autograft because she did not have symblepharon formation. This is another 45-year-old male patient who was an industrialist, ended up with the injury with a disinfectant powder almost 30 years back, and he kept on moving from one place to the other with recurrent surface breakdown and inflammation. We did a slat and CAG for this, and 2 years post-surgery, the eye has been very stabilized. So this is another clinical case. At times, we would like to do allolimbal transplantation, and that is indicated in living-related donor, cadaveric fresh donor tissue we can use. Alloslat, usually we take large claw covers of donor tissue, or sometimes one can take a pinch biopsy from the fresh donor limbus. Since it is allogenic tissue, it needs long-term systemic immunosuppression. For bilaterally injured or damaged cases, this can work as a boon to visually rehabilitate these eyes, especially chronic VKC and chemical injury patients. So to summarize, one can customize the treatment based on clinical condition. Techniques of limbal transplantation have evolved greatly over last decade, and SLAT combines the advantages of both conjunctival limbal autograft and CLAT, and is a simple, inexpensive, single-stage technique with anatomical and functional success rates equal to or higher as compared to conjunctival limbal autograft or CLAT. The cost is significantly lower with SLAT as compared to CLAT. In the setting of bilateral limbal stem cell deficiency, allogenic SLAT is a potential option, but it will require long-term systemic immunosuppression. However, alloslat from cadaveric donor is being used to stabilize the ocular surface quickly in severe bilateral acute chemical injury recently with good outcomes. So to summarize, the key points for successful outcomes in these cases would be prior control of inflammation, counseling for the outcomes, and need for long-term follow-up of these cases for good success. Thank you for your kind attention, sorry.